main finding, the primary endpoint was all-cause death and heart failure hospitalization. We could show that digitoxin on top of a well-implemented heart failure therapy reduced the primary endpoint significantly with a hazard ratio of 0.82%, so 18% risk reduction, which was highly significant. And also this means we have an absolute risk reduction of 4.6%, and patient needed to treat during the trial period to prevent one primary endpoint event was 22. We tried to perform a simple and easy to transfer trial design into clinical practice. The former heart failure trials with reduced ejection fraction usually have enrichment of the risk populations, such they want thresholds for brain neurogenic peptides, for example, or patient had to be hospitalized the last 12 months for heart failure. And we try to avoid this because we really want to keep a simple trial design transferable to the clinical routine. So we basically took all comers with heart failure with reduced ejection fraction, with the ejection fraction below or equal to 40%, New York Heart Association class 2 to 4, and they had to be treated for 6 months. So this has to be a chronic heart failure population, and we aim to have a very well implemented guideline-directed medical therapy, which we achieved this goal, because 95% of the patient had beta blockers, above 90% have inhibitors of the renin-angiotensin system, 76% mineralocorticoid receptor antagonists, ANIs 40%, and SGLT2 was a little bit lower because the trial was running during the time when the drugs were available for heart failure. So 20% with SGLT2 inhibitors. So we have a really well implemented medical therapy, but also, which is probably typical for Germany, a high rate of implantable cardiodefibrillators, about 65%, and 25% on cardiac synchronization therapy. So, and this was important for us also to show that the effect of digitoxin was on top of the well-implemented therapy. And as I said, we performed a really simple trial design, placebo versus digitoxin in this patient population. There was a simple dosing protocol. We did one-time serum concentration after 6 weeks, and after that we did a short titration period, and then the patient were running in the trial for a couple of years without additional dose controls. We decided to use digitoxin because there weren't any data available for digitoxin, and we could not run a triple-arm trial. Initially we planned this, placebo, digitoxin, but for funding reasons this was not possible. And we saw this because the enrollment even then was difficult, but despite we enrolled less people, we reached the goal and showed that the primary endpoint was positive, affected by digitoxin. I think from the pharmacodynamics, digitoxin and digitoxin are clearly comparable. The pharmacokinetics is a major difference, because especially kidney function, patients with reduced impaired kidney function, they have sometimes, or if it's advanced, accumulation of digoxin and then high levels, and that's a problem in the trials probably also. This you do not have with digitoxin, even if you have impaired advanced kidney function dysfunction, like patients who need dialysis. You can treat them, and you do not have problem with the serum concentrations getting up. That was the major reason why we used digitoxin. And I think we have to wait. If you put the context of the digit-HF data with the DIG trial, I think we have good reasons at least to use digoxin in countries where digitoxin is not available, in patients who still are in need for treatment because they are highly symptomatic and have advanced heart failure. But of course we have to wait probably for the decision trial, which is next year, most likely published by the Netherlands group of Dirk van Veldhuizen, investigating digoxin in a HFrEF population. But if we have all these data together, then I think we really can make safe conclusions regarding comparability of digoxin and digitoxin. But in the countries where digitoxin is available, I think there's no reason not to use it nowadays. And there are probably, like India and China, it's not clearly clear if it's in use. There's a huge population probably available, and then we have to wait for the digoxin data.